Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help.
Welcome back to the Wild Health Podcast. Today is March 27th. Today, the CDC reported that as of yesterday evening on Thursday, there were 85,356 cases, 1,246 deaths in the U.S. This represents a 25% increase in both cases and deaths. The case fatality rate is currently 1.46% and has remained below 1.5% for the past week. As of the time of this recording, according to worldometer.com, there are currently 96,968 cases in the U.S. and 1,477 deaths. Governor Cuomo of New York City recently had a press conference. They stated that the apex of hospital need is likely to be in 21 days from now. They expect to need a total of 40,000 ICU beds, and they currently have 3,000 and 3,000 ventilators. So they're going to have to try to find an additional 37,000 ICU beds. They plan to use colleges, dormitories, hotels, nursing homes, and all of those are possible spaces that they could convert into hospital beds if needed.
In my mind, one of the scary things about this number is how much it's changed over just the last few days. The last time I saw an estimate, they were thinking somewhere between 18,000 and 36 or 37,000 ICU beds, and now they're talking about needing 40,000. So doesn't seem to be slowing down that much in New York. As far as global updates, the U.S. now has more confirmed cases than any other country in the world and continues on a steep trajectory, doubling every 2 days. Data from the Financial Times showed that the U.S. death toll has steepened, surpassing the number of deaths in both Iran and China at the same stage, but remaining behind Italy. In Italy, there were 5,909 new cases and 919 new deaths in the last day. This is the highest number of new deaths since the beginning of the epidemic in Italy. 46 doctors have died to date, 4 additional deaths today. In total, 6,414 healthcare workers have tested positive. Boris Johnson, UK's Prime Minister, announced today that he tested positive for COVID and has mild symptoms as well.
The New York Times released an article on March 25th that uses an interactive model to better help understand the side effects of stopping social isolation program early. The model shows that if social distancing were eradicated in 2 weeks, so roughly around Easter, then a total of 126 million people could contract the disease in the U.S. and 1.3 million people could die. Alternatively, if we continue to socially isolate for 2 months, 14 million would be infected and an estimated 80,000 would die. This will not come without a significant cost. Multiple economists predict models with showing a significant economic impact secondary to social distancing. However, many models suggest the effect of non-mitigated pandemic could be as bad, if not worse, than social distancing. So there's obviously no way to know for sure, but I have personal trouble imagining a scenario where we choose economy over human life.
Well, let's talk about that for just a second. We should preface this by saying we're physicians, not economists. But my undergraduate degree actually was in economics, and I really enjoy thinking about and talking about this. I mean, obviously, if we're choosing life over economics, we have to choose life. We're talking about 1 million extra lives. But what if you were only concerned with the dollars, with the numbers here, and the dollars and cents? Right now, social distancing, there is a cost to this, to the economy, but what kind of wealth destruction is actually happening? This isn't like a war where buildings are being destroyed, infrastructure is being bombed. We're pausing the economy. And I know the U.S. economy runs largely on consumer spending, and so there is a negative effect. But imagine the negative effect just in dollar terms if an extra million people die. And this is just the mortality. If you think about the morbidity, Mike, we've talked about how up to 15% of people have long-term damage to their lungs. The cardiomyopathy rate is really high. Imagine, so again, if the mortality rate is 1.5% and we're talking about 1.3 potentially dying, then we're also talking about 15 million in the tens of millions having long-term damage. Think about the cost to the economy that we all have to pay for if you're just thinking about dollars. So we have to just stop for a second. And first off, it's a ridiculous comparison to think about the economics versus human life. But if you're just completely self-interested in just thinking about your pocketbook, it still does not make sense. And I, as much as anyone else, cannot wait to eat out in a restaurant or take my kids to Disney World or do these things. But this is a really short-sighted view, in my opinion, as not an economist. But I just have to say that because I get very shocked at this argument frequently that I hear about we're not going to get political at all, but just, think about the numbers in terms of the cost of the economy, if nothing else, just from the morbidity and mortality associated with the increase. And this is not a political thing. These are models that real economists and people who know what they're talking about are putting out there. So just think about those numbers.
I've read quite a few of these economic assessments by multiple different economists, and what some of them are arguing is that basically with a significant recession, you're going to see basically death and morbidity as well. I think I find those models a little bit harder to personally believe, maybe because it's a little less tangible than a virus that we know is making its way throughout the entire world right now, leaving a wake of dead people. But it does bring forth an interesting argument. What I find the most interesting though is that the numbers, and I recently tweeted and put one of these graphs on our Instagram account. It's @WildHealthMD. And it's basically a graph comparing no mitigation, so no social distancing, to social distancing, and looking at the change in the GDP of the U.S. economy and the effect on the U.S. economy. And if you play it out, it's very similar. Like the total effect on our economy is very similar, independent of whether we are social distancing or not. Because if we're not social distancing, then just like you were saying, Matt, so many more people are going to die, and there's going to be such a loss in the economy just from the death and from the disruption of the overwhelmed healthcare system. So I don't think there's, in my mind, there's a clear answer here, and the answer is towards human life. But in terms of the economic impact, I'm not sure there is a clear answer, and I think economists disagree as to what makes the most sense in terms of what's best for the economy, even if we take that independent of human life.
Yeah, and I've heard some people talk about increased suicides and things like that with a down economy. So there were, in the financial crisis 2008, I remember there was an uptick in suicide. So maybe there's something there. But I just looked this up, Mike, as you were talking, and in the United States in 2018, most recently, there were 48,000 recorded suicides. So what if the suicide rate doubles because of a down economy? Then you're talking about at maximum an extra 50,000 deaths. Now compare that to the difference in 1 million deaths by opening up in a couple weeks versus a couple months. So I don't think that argument about life and suicide that I've heard some people make is even close to being accurate when you look at the numbers. And I think we have to trust the experts here and not necessarily people with very clear incentives.
Other literature that I wanted to go over today includes another article on the ACE2 front. So angiotensin converting enzyme 2 is basically the enzyme that the coronavirus attaches to get into our cells. So this is an article that's pre-published. It has not been peer-reviewed yet. It was released on March 25th. It's called Renin-Angiotensin-Aldosterone System, a double-edged sword in COVID infection. The review article really just discusses the sort of the complicated system that is the angiotensin and ACE2 expression and how it relates to COVID-19. And the author makes an interesting argument, and that's the concept of timing of ACE2 expression and how it could be important to prevent the cytokine storm and to time the immune system response to COVID-19. My take on this concept, this whole ACE2 discussion, is that I think ACE2 clearly plays a role, and I think everyone agrees with that. We all want to speculate what that role is, and we all want to jump to conclusions about medications and supplements that may upregulate or downregulate ACE2 expression. But realistically, this is an extremely complicated system. It's related to blood pressure, cytokine storm, inflammation, viral adherence, infectivity. I'm really skeptical of anyone right now that claims to understand how this thing actually works. I suspect that what we're going to have to end up doing, Matt, is actually sort of eclipse the physiology and our understanding of how the whole system works and jump straight to outcomes. And that's going to basically take a randomized control trial with known compounds that modulate ACE2 expression, things like ACE inhibitors or ARBs. I don't think that we can really pretend like we truly understand this entire system and how the COVID virus interacts with ACE2. Another interesting article I wanted to go over today is donor plasma for COVID patients. So this is an article that was just released in JAMA on March 27th called Treatment of 5 Critically Ill Patients with COVID-19 with Convalescent Plasma. This is a case series of 5 critically ill patients in China. They all had COVID-19. They all had acute respiratory distress syndrome or ARDS. They were all being ventilated, and they had all continuously high viral loads despite antiviral treatment. So these were people who were very, very, very ill with a mortality probably somewhere around 40 to 50%, estimated just based on looking at some of the data that I've previously seen. After getting the plasma from patients who had COVID and basically fought off the infection and had antibodies, 3 out of 5 of these patients have now been discharged from the hospital, and the other 2 are off ventilators and in stable condition. So this is obviously an extremely small study of 5 people, but it is encouraging that plasma could actually be helpful to fight patients, at least in patients with severe disease, help fight off the COVID infection.
Yeah, it's very encouraging, and I think these trials are going to progress really rapidly. We have some listener questions. What's your take on face masks versus N95s for non-aerosolized patients? I've seen mixed things, including the recent article at New Yorker magazine showing face mask use and distancing in Singapore. Thoughts? I would just say Brian Atkins and I did a PPE podcast that was actually just released this morning, and we talked a little bit about how there is some protection with face masks in general. N95s are going to be the best, but I think there is some data that face masks are better from nothing.
I was just going to say that I don't think this is a sort of a yes-no answer. I think that some PPE is helpful. More PPE is probably more helpful. So sure, if you were wearing, a respirator and a Tyvek suit with all of your, creases duct taped, that'd probably be more beneficial, but it's probably unrealistic to actually try to get that level of personal protective equipment. I think that there's benefit from a surgical mask only, and there's probably more benefit from an N95. I certainly think that the data is there with that aerosolizing procedures definitely need an N95. We know that the virus lives for hours in aerosolized droplets. So I don't doubt that whatsoever. In terms of just general interaction with people, unless you're doing something really interventional, I think that a lower level of PPE is probably acceptable. And I know that there's some hospitals that have moved to lower levels of PPE, partially, I think, because they're trying to conserve N95 masks for the sicker patients and the patients requiring more significant intervention.
Yeah, I think it depends on your resources. If you're getting ready to walk into a patient's room who's coughing and is COVID positive and you got one N95 left, well, maybe you're going to use it, but if you also know you're going to have to intubate 3 patients later in the shift, maybe you don't. I mean, I think this is going to be a game time decision. We know which ones are best. We know any barrier is probably better than nothing. So this is going to be an individualized decision, I think, patient to patient. Speaking of masks, another person says, my friend is a nurse on the medical floor. The hospital will not supply nor will they allow floor RNs to don masks, even if they bring their own. What do you think about this large hospital refusing medical staff the ability to don masks? She is very uncomfortable with this. I think I would want to talk to the hospital administrators and see why. I feel like there's probably a good reason. If I had to speculate, they may say, number one, they don't think there's enough masks to go around, and the low risk places, they're probably saying not to wear masks in order to conserve. I 100% understand her being uncomfortable with this, especially if she brought her own. I think if I'm an administrator, I'm thinking, okay, well, if a couple nurses have it, the other ones are going to want it. So I could kind of see why they would make that decision. But at the same time, this is a ridiculous discussion and decision to be having to make when you think about the actual cost of these. This is just an issue that we have to get more masks and more supplies to hospitals. We have the resources in this country to do it. We just got to figure out a way to do that. I want to read, we got an interesting email today. We were talking most of the time to patients and the general public on this podcast and the updates, but occasionally we do like to communicate with our colleagues on the front line, and so this is what this is going to be. I apologize if it doesn't make a lot of sense to you if you're not in medicine, but this is a kind of a letter from a physician in New Orleans. Has been practicing about 20 years, and they say that every one of my colleagues have now seen several hundred COVID-19 patients, and this is what I think I know. I feel like this is a valuable thing just to let other physicians who may not be in the hot zones yet to just kind of know what's coming, to be a little more prepared. The quote is, "This clinical course is predictable. 2 to 11 days after exposure, day 5 on average, flu-like symptoms start. The common symptoms are fever, headache, dry cough, myalgias, back pain, nausea without vomiting, abdominal discomfort with some diarrhea, loss of smell, anorexia, fatigue. On day 5 of symptoms, there's usually increased shortness of breath and bilateral viral pneumonia from direct viral damage to the lung parenchyma. On day 10, we get cytokine storm leading to acute ARDS and multi-organ failure. You can literally watch it happen in a matter of hours. So far, 81% of patients have mild symptoms, 14% severe symptoms requiring hospitalization, and 5% critically ill. The patient presentation is varied. Patients are coming in hypoxic, even 75% without dyspnea. I have seen COVID patients present with encephalopathy, renal failure from dehydration, and DKA. I've seen the bilateral interstitial pneumonia on the x-ray of the asymptomatic shoulder dislocation or on the CT of an asymptomatic polytrauma patient. Essentially, if they're in my ER, they have it. I've seen 3 positive flu swabs in 2 weeks, and all 3 had COVID-19 as well. Somehow, this has told all the other disease processes to get out of town. So they're just making a quote that this is kind of happening to everybody, no matter what, if anything else is going on as well. Going back to quoting now, China reported 15% cardiac involvement. I have seen COVID-19 patients present with myocarditis, pericarditis, new onset congestive heart failure, and new onset atrial fibrillation. I still order a troponin, that's a cardiac enzyme, but no cardiologist will treat, no matter what the number of the troponin in a suspected COVID-19 patients. Even our non-COVID-19 STEMIs, that's an acute heart attack, at all of our facilities are getting TPA in the ED and rescue PCI at 60 minutes, only if TPA fails. So for those of you listening, that's definitely a deviation from what standard would normally be. Now I'm quoting again. Diagnostic. On the chest x-ray, we see bilateral interstitial pneumonia. Anecdotally, it starts most often in the right lower lobe, so bilateral on chest x-ray is not required to make the diagnosis. The hypoxia does not correlate with the chest x-ray findings. The lungs do not sound bad. Keep your stethoscope in your pocket and evaluate with your eyes and pulse ox. For labs, the white blood cell count is frequently low, lymphocytes low, platelets lower than normal, procalcitonin normal at about 95%. CRP and ferritin are elevated most often. CPK, D-dimer, LDH, alk phos, AST/ALT commonly elevated. Notice the D-dimer. I would be very careful about CTPEing these patients for their hypoxia. The patients receiving IV contrast are going into renal failure and on the vent sooner. So what he's saying here is normally a patient in the ER, if we have a positive D-dimer, we do a CT angiogram to look for a blood clot in the lungs, but that could have negative outcomes in these patients. Going back to quoting now. Basically, if you have a bilateral pneumonia with normal to low white blood cells, lymphopenia, normal procalcitonin, elevated CRP and ferritin, you have COVID-19 and do not need a nasal swab to tell you that. A ratio of absolute neutrophil count to absolute lymphocyte count greater than 3.5 may be the highest predictor of poor outcome. The UK is automatically intubating these patients for expected outcomes, regardless of their clinical presentation. An elevated IL-6 is an indicator of their cytokine storm. If this is elevated, watch these patients closely with both eyes. Other factors that appear to be predictive of poor outcomes are thrombocytopenia and LFTs 5 times the upper limit of normal. The disposition. I had never discharged multifocal pneumonia before. Now I personally do it 12 to 15 times a shift. 2 weeks ago, we were admitting anyone who needed supplemental oxygen. Now we are discharging with oxygen if the patient is comfortable and oxygenating above 92% on nasal cannula. We have contracted with a company that sends a paramedic to their home twice daily to check on them and record a pulse ox. We know many of these patients will bounce back, but if it saves a bed for a day, we have accomplished something. Obviously, we are fearful some won't make it back. We are a small community hospital. Our 22-bed ICU and now a 4-bed endoscopy suite are all COVID-19 patients. All of these patients are intubated except one. 75% of our floor beds have been cohorted into COVID-19 wards and are full. We are averaging 4 rescue intubations a day on the floor. We now have 9 vented patients in our ER transferred down from the floor after intubation. Luckily, we are a part of a larger hospital group. Our main teaching hospital repurposed space to open 50 new COVID-19 ICU beds this past Sunday, so these numbers are with significant decompression. Today, those 50 beds are full. They are opening 30 more by Friday. But even with the quote-unquote lockdown, our AI models are expecting a 200 to 400% increase in COVID-19 patients by April 4th. Treatment is supportive. Worldwide, 86% of COVID-19 patients that go on a vent have died. Seattle is reporting 70%. Our hospital has had 5 deaths and 1 patient who is extubated. Extubation happens on day 10 per the Chinese and day 11 per Seattle. Plaquenil, or hydroxychloroquine, which has weak ACE2 blockade, doesn't appear to be a savior of any kind in our patient population. Theoretically, it may have some prophylactic properties, but so far it is difficult to see the benefit to our hospitalized patients, but we are using it and the studies will tell. With hydroxychloroquine's potential QT prolongation and liver toxic effects, both particularly problematic in COVID-19 patients, I am no longer selectively prescribing this medication, as I stated prior. We are also using azithromycin, but we're intermittently running out of it IV. Do not give these patients standard sepsis fluid resuscitation. Be very judicious with the fluids as it hastens their respiratory decompensation. Outside the DKA and renal failure dehydration, leave them dry. Proning vented patients significantly helps oxygenation. Even self-proning the ones on nasal cannula helps. Vent settings. Usual ARDS stuff. Low volume, permissive hypercapnia, except for PEEPA 5 will not do. Start at 14 and you may go up to 25 if needed. Do not use BiPAP. It does not work well and is a significant exposure risk with high levels of aerosolized virus to you and your staff. Even after a cough or sneeze, this virus can aerosolize up to 3 hours. The same goes for nebulizer treatments. Use an MDI instead. You can give 8 to 10 puffs at one time of an albuterol MDI. Use only if wheezing, which isn't often in COVID-19. If you have to give a nebulizer, this must be in a negative pressure room, and if you can, instruct the patient on how to start it after you leave the room. Do not use steroids, it makes this worse. Push out to your urgent cares to stop their usual practice of steroid shots for their URI and bronchitis. We are currently out of Versed, fentanyl, and intermittently propofol. Get the dosing of Precedex back in your heads. One of my colleagues, who is a 31-year-old female who graduated residency last May with no health problems and normal BMI, is out with the symptoms and has a saturation of 92%. She will be the first of many. I use PPE the best I can. I do wear a MaxAir PAPR the entire shift. I do not take it off to eat or drink during the shift. I undress in the garage and go straight to the shower. My wife and kids fled to her parents' house outside Hattiesburg. The stress and exposure at work, coupled with isolation at home, is trying. But everyone is going through something right now. Everyone is scared, patients and employees. But we are the leaders of that emergency room. Be nice to your nurses and staff. Show by example how to tackle this crisis head on. And good luck to us all. I apologize if you don't know exactly what all of those words mean. As an ER physician, I got chills reading some of that. It doesn't paint a great picture, but I do think there is a lot of useful information in there for physicians who are on the front lines, and I do think it's information worth sharing. It's not true statistics. It's not a randomized study. And results in different places with different populations may be different, but I do think there's some valuable information there.
No, I just, as you were reading through that, Matt, I was sort of thinking to myself how amazing it is, the world that we're currently living in, and how quickly physicians across the world can speak to one another and give personal advice like that. I think that my guess is it's going to change the outcome of the toll that this virus takes on our society. So thank you to that physician for sharing their experience, and to all the other physicians and nurses and healthcare providers who have shared their own personal experiences, because they're extremely important for the areas of the country where the virus hasn't hit as hard, but is likely going to in a matter of days to weeks.
Thanks for listening. We'll be back tomorrow morning and tomorrow evening, and until then, stay safe.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.